Dr. Birgit Khandalavala, and I'm from the Department of Family Medicine. I'm board certified in both family medicine as well as in obesity medicine. And today I'm here to give you a little bit of an update on obesity medicine for 2014. Actually, 2013 was one of the best years in obesity medicine. We really had a lot of game changers, a lot of good things that have happened in our field, and so I expect 2014 to be an even better year for those of us who work in obesity. And the reason I was so excited in 2013 was that the AMA made a declaration, which is the American Medical Association, in July of 2013, that actually made obesity a disease. And previous to this, people always thought of obesity as a problem of willpower or laziness, or just not doing what they're supposed to do. And so it's been really exciting for us that it is now recognized as a disease, because I think this will open the door for us to start treating obesity seriously. And why did this change? One of the reasons this changed is because obesity is a very complex disease. Then there are many reasons for it, whether it's genetic, whether it's behavioral, whether it's the environment. There are many things we're beginning to understand now about obesity that we probably didn't know previously. Definitely it's not a problem of willpower. More than likely is to do with one's genetics, being in the wrong environment that we are all too well aware of in our what we call obesogenic environment today. And we definitely feel that by recognizing this as a disease, that early treatment will help reduce the complications, because once we have weight, it's really a lifelong battle. So we do have something which I'll go through with you called the Obesity Pledge, and in that we state, I treat obesity seriously. I believe obesity isn't just a problem. It's a disease that warrants serious, evidence-based treatments, whether these are nutritional, physical activity, intensive behavior counseling, drug therapy, or surgery. I agree to learn and help more, and I treat obesity seriously. The reason we came up with this was because, as I mentioned shortly, there's a combination of genetics. If you don't have the genetics, you probably will not have an issue. If you don't have the environment, you won't have an issue. But when we have the perfect storm in our present day, where we have genetics that we were not meant for this obesogenic, we have this epidemic. And as a result of this, we're having epidemics of obesity, diabetes, and a whole bunch of other serious health problems. Roughly about 1/3 of the population currently is obese, but more importantly, what we are concerned is about childhood obesity. So how do we measure obesity? The first thing that we do is we look at the height, we look at the weight, and we kind of come up with a very imperative number called the BMI, or body mass index. There are issues with this, with the BMI, because there would be people like the Huskers in this situation who would all be in the red and would be candidates for bariatric surgery, and there would be probably smokers in this in the green who probably should not be smoking and may even gain weight, but they happen to be in the green. So this is very subjective in a way, but it is a very useful method of finding out, at least for screening, who is obese, who is not. We also look at the waist circumference, maybe other different things on the blood work to decide who really should be treated. But right now the guidelines are based on the BMI. And why are we so interested in the BMI? Because based on the BMI, roughly we see the number of complications going up. Most people associate diabetes and obesity, and that seems to be the more common connection. However, there are some more sinister connections between weight and your metabolic health. We see sleep apnea, we're seeing fatty liver in children, we are seeing probably even cancers such as the breast, uterus, and colon that are connected. And there are even some preliminary data to suggest that dementia, for example, can be related probably with the waist circumference or maybe even with weight. So all this makes it imperative for us to look into options. How much weight should we lose? I know this may not seem much, but about 7% of weight loss, before you have diabetes, would reduce your progression of diabetes 58%. So it doesn't mean that you have to lose a lot of weight all the time. Small amounts can make a big difference. Definitely for some folks, 15 to 30% of weight loss is important, especially when you have mechanical problems, joint problems, and others. So based on the BMI, we kind of categorize what kind of options you would have available. And if you have a BMI over 27 with one health-related comorbidity, you'd be a candidate for the medical management. If it's 35, you could definitely look at surgery. But for everybody, we should probably be looking at what we call intensive lifestyle modification. And what does this entail? Basically, it entails looking at your diet or your nutrition. We're trying to move away from the word diet to nutrition, looking at your dietary patterns, maybe getting rid of pop, eating a breakfast. We're looking not so much at exercise, but as physical activity. Is more important probably to be active throughout the day. And very, very importantly, we're looking at sleep. There are systems such as the Nutri-System meal replacement program that can be very useful for certain folks, and this is really what we call the lifestyle modification. Above that, if you're still struggling and you've tried all this, probably a medication would be appropriate, and if you really are a candidate, maybe even bariatric surgery. I do see in 2014 that we'll be using a lot more technology. I think this is a good time. Your smartphone is probably going to become your best friend. So will a dog, but so will your smartphone. And you can definitely use that to track whether it's a fitness band, whether it's a Nike. They have these little bands now that people can clip on or tag on out here. They tell you your sleep, your nutrition, your activity. They even tell you if you're stressed out and how to calm down. So I do feel that we need to make more use of these smart technologies to give us feedback, to see what are we doing different, how can we improve ourselves. And I really would encourage people to use these newer technologies, apps, and different kind of resources that we have available that are getting better by the minute. So diet and exercise, or I would say nutrition and physical activity, help people lose a little bit of weight. And then of course we have the bariatric surgery part here, but there was what we call a treatment gap, where people who needed to lose 5-10% really didn't have much options. And this is why 2013 and now even 2014 is going to be a better year, because we actually have 2 new FDA approved medications. Previous to this, we had some that were meant for short term. They really hadn't been studied. They were not FDA approved. They had too many problems. They got taken off the market. But today we have 2 new medications. These do have to be used in association with the lifestyle. So doing a medication by itself without doing the lifestyle probably is not the best idea. These medications are FDA approved, but before I even go to them, the first thing I look at when somebody comes to me is that if they are on one medication, is this medication in any way causing them to produce weight? Because about 10% of medications are known to cause weight gain. For example, if you're an antidepressant, maybe switching out one for another one maybe help people already start budging that scale. So the 2 new weight loss medications go by different brand names. One is a combination of 2 generics, and the other one is a newer, completely novel kind of a medication. Both of them have to meet certain criteria. They're a little pricey right now, and we do expect that more and more insurances are going to start covering, but they are available. And I expect that with advocacy at multiple levels, with the new healthcare changes, that more and more medications will be covered, plus maybe new medications can be discovered. For example, in hypertension, we have about 30 medications for hypertension, and we have 2 only for obesity. Whereas if we treat the obesity, maybe we won't have to treat so many other different medications and different conditions. And hence this has been very exciting for us. So I'd like to end with 3 points. One is that obesity is a heterogeneous chronic disease. We don't like anything short term. Anything that works for a month, 2 months, no. You're probably looking at 1 to 2 to 5 years, especially women and children. Number 2 is that we need to treat obesity just like you treat diabetes. You stop your diabetic medication, diabetes is going to come back. You stop your blood pressure medication, so it'll come back. So it has to be long term and hopefully safe. And number 3 is that for some folks, diet and exercise is not enough. You do have to look at stronger tools, different options, but wherever you are, you can make a difference where you are today in your family. I'm really excited about 2014 because I think we'll have new choices, newer medications, newer ways of using technology, and I think it's going to be the best year in obesity medicine. Thank you.
Stay tuned. We have Dr. Corey McBride coming up momentarily talking about surgical weight loss options.